The dementias, multi-infarct dementia and Alzheimer's disease. Dementia reportedly affects 3% to 11% of community residing adults older than 65 years of age and 20% to 50% of community residing adults older than age 85. In order for the diagnosis of dementia to be made, at least two domains of altered function must exist: memory and at least one of the following: language, perception, visuospatial function, calculation, judgment, abstraction, and problem solving. Symptoms are usually subtle in onset and often progressively until they are obvious and devastating. The changes characterized of dementia fall into three general categories: cognitive, functional, and behavioral. Reversible causes of dementia include alcohol abuse, medication use, polypharmacy, and psychiatric disorders, and normal pressure hydrocephalus. The three most common non-reversible dementias are Alzheimer's disease, multi-infarct dementia, and mixed Alzheimer's and multi-infarct dementia. Alzheimer's disease accounts for more than 60% of all dementias, and multi-infarct dementia, vascular dementia, also called vascular dementia, accounts for another 5 to 20%. Other non-Alzheimer's dementias include Parkinson's disease, AIDS-related dementia, and Pick's disease. Pick's disease. Dementia is characterized by an uneven downward decline in mental function. Multi-infarct dementia is sometimes confused with Alzheimer's disease, paranoia, or delirium because of its unpredictable clinical course. The diagnosis can be even more difficult if the patient is suffering from both Alzheimer's disease and multi-infarct dementia. Multi-infarct or vascular dementia has the following defining characteristics. Number 1, there must be evidence of dementia. Number 2, there must be evidence of cerebrovascular disease by history, clinical examination, or brain imaging. Number 3, the two disorders must be reasonably related. Alzheimer's disease is a progressive, irreversible, degenerative neurologic disease that begins insidiously and is characterized by gradual losses of cognitive function and disturbances in behavior and affect. Its onset occurs in middle age. A family history of Alzheimer's disease and the presence of Down syndrome are two established risk factors for Alzheimer's disease. If family members have at least one other relative with Alzheimer's disease, then a familial component, which non-specifically includes both environmental triggers and genetic determinants. Genetic studies show that autosomal dominant forms of Alzheimer's disease are associated with early onset and early death. Pathophysiology: specific neuropathologic and biochemical changes are found in patients with Alzheimer's disease. These include neurofibrillary tangles, a tangled mass of non-functioning neurons, and senile or neuritic plaques, that is, deposits of amyloid protein, part of larger protein in the brain, APP, that is called APP. And this neuronal damage occurs primarily in the cerebral cortex and results in decreased brain size. Similar changes are found to a lesser extent in the normal brain tissue of older adult. Cells that use the neurotransmitter acetylcholine are the ones principally affected by this disease. Biochemically, the enzyme active is producing acetylcholine, which is specifically involved in memory processing, is decreased. Clinical manifestations: in the early stages of Alzheimer's disease, forgetfulness and subtle memory loss occur. The patient may experience small difficulties in work or social activities but has adequate cognitive function to hide the loss and can function independently. Depression may occur at this time. With the further progression of the disease, the deficits can no longer be concealed. Forgetfulness is manifested in many daily actions. These patients may lose their ability to recognize familiar faces, places, and objects and may get lost in familiar environment. They may repeat the same stories because they forgot that they have already told them. Conversation becomes difficult and there are word finding difficulties. The patient may become depressed, suspicious, paranoid, hostile, and even combative. Progression of the disease intensifies the symptoms. Speaking skills deteriorate to nonsense syllables. Agitation and physical activity increase, and the patient may wander at night. Assessment and diagnostic findings. The health history, including medical history, family history, social and cultural history, medication history, and the physical examination, including functional and mental health status, are key in the diagnosis of probable Alzheimer's disease. Diagnostic tests, including complete blood count, the venereal disease research laboratory VDRL test for syphilis, HIV testing, chemistry profile, and vitamin B12 and thyroid hormone levels, as well as screening with electroencephalography EEG, computer tomography CT, magnetic resonance imaging MRI, and examination of the cerebrospinal fluid may also refute or support a diagnosis of probable Alzheimer's disease. A depression scale is helpful in screening for underlying depression. Tests for cognitive functions such as the mini mental state examination and the clock drawing test are useful for screening. The diagnosis can be confirmed only by cerebral biopsy. Medical management. The first medication for treatment of the symptoms Alzheimer's disease, tacrine hydrochloride, Cognex, TACRINE, tacrine hydrochloride, Cognex, that is COGNEX, Cognex. This agent enhances acetylcholine uptake in the brain, thus maintaining memory skills for a period of time. Because this medication can cause liver toxicity, patient must be closely monitored. The second drug is Donepezil, DONEPEZIL, Aricept, ARICEPT, Donepezil, that is Aricept, is a second medication in this category of acetylcholinesterase inhibitors. A third medication in this class is rivastigmine, 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 that is Exelon, EXELON, Exelon was introduced. These two newer preparations have far fewer side effects, although they continue to require ongoing monitoring. Nursing management. Nursing interventions are aimed at maintaining the patient's physical safety, reducing anxiety and agitation, improving communication, promoting independence in self-care activities, providing for patients' needs for socialization, self-esteem, and intimacy, maintaining adequate nutrition, managing sleep pattern disturbances, and supporting and educating family caregivers. Thank you.